हाँ मैम. हाँ, जुपिटर हॉस्पिटल, डॉक्टर एल एच हिरानंदानी हॉस्पिटल पवई. That's it, and my clinic. In Thane. Thane. Bethany, yeah. I mean, Hiranandani, yes. CMC Vellore. I did a 2-year fellowship. MD from Kottayam, Kerala. Thank you so much, man. Yeah, I have already logged in, ma'am, actually. Okay.
You uploaded your slides, Raheesh? You're ready, now? Raheesh?
Hello, ma'am.
Yeah. Have you uploaded your slides and all that? You said, no?
Yeah, I am all set, ma'am.
Okay. We wait for some time and then start.
Shall we start, ma'am?
What's the time now? 10, 11 seconds. Wait for 3-4 minutes.
Yeah, sure, ma'am.
11:05. Start. Yes, Raheesh, I think we can start. Good morning, everybody. Good morning, everybody. We start with our session on approach to vasculitis. We have Dr. Raheesh Ravindran here, who's going to enlighten us on this topic. Dr. Raheesh is a postgraduate from Kerala Medical College, and after that, he has pursued his uh, fellowship in rheumatology at CMC Vellore. Shifted to Bombay, and he's a consultant rheumatologist at Bethany Hospital in Thane, at Jupiter Hospital in Thane, and at Hiranandan Hospital. He's going to speak to us on approach to vasculitis. Over to you, Raheesh.
Okay, ma'am. Thank you so much, ma'am. A happy wish to everybody. So today is the Kerala equivalent of the Gudi Padwa happening. So I'll start off my talk. So is my screen visible?
Not as
Is it visible to everybody?
not as yet.
I've started sharing. Has it come?
No, Raheesh. Yeah, it's coming.
Yeah. Okay. So fine. So I'll start off with two cases just to give you a hang of how vasculitis presents in day-to-day practice. So case one is it's a 36-year-old female who came to us with a history of recurrent sinusitis in the past, one episode of eye redness in the last 4 weeks, recent onset dry cough, and which gradually progressed to one episode of hemoptysis. And within a day, she developed acute breathlessness and she was brought to the casualty for the same. On clinical examination, there was no skin rashes, no obvious physical findings except for the chest findings, which showed diffuse crackles, rales, bronchial breath sounds, wheezing, and crackles at the base of the lung. So a chest X-ray showed diffuse fluffy shadows, which was suggestive of possible alveolar hemorrhage. The CT scan, which followed up, showed us the same picture. So she came in with diffuse alveolar hemorrhage with a background history of upper respiratory symptoms. Her blood workup showed a hemoglobin of 8.6, a total count of 13,000, creatinine of 2.1, which is on the higher side. Urine showed casts and RBCs. We did our autoimmune workup. ANA was negative. The CANCA was positive. PR3 more than 200. C3, C4 was normal. So considering the clinical picture, the primary diagnosis for her was made as GPA with pulmonary renal syndrome. So this is a presentation of a small vessel vasculitis. Another case, a young lady, 17-year-old female, came to us with progressive gangrenous changes over bilateral hands and feet. The coagulation workup was negative. No other history of connective tissue disorder. No, all the serologies that were sent for vasculitis were negative. NCV showed sensory motor demyelinating axonal neuropathy, and the nerve biopsy showed vasculitis. So the diagnosis was systemic vasculitis, medium vessel vasculitis, pan-like presentation. So as you've seen in these two cases, both of the presentations were quite debilitating for the patient. The second case, she lost 5 of her fingers. The first case came with severe diffuse alveolar hemorrhage, which was life-threatening. Both of them did survive, did well with therapy, but vasculitis can present with very life-threatening presentations. So early diagnosis and early therapy is the key to having a better outcome. So to understanding vasculitis, we need to understand how to pick these diseases early in the course of their presentation so that we can act accordingly and appropriately. So we'll go into the basic approach to vasculitis so that we can understand how to pick up vasculitis in our clinical practice. So what is vasculitis? Basically, vasculitis are defined by presence of inflammatory leukocytes in the vessel wall with reactive damage to the neural structures. You can see in the diagram, the tunica adventitia, the tunica media, the tunica intima with the external and the internal elastic lamina. So in the picture down with the changes seen in vasculitis, you see all the structures are damaged and there is obstruction of the lumen. This is what happens, and this is the basic pathology of vasculitis. So same in a different format, inflammation causing to aneurysms can cause to tissue damage, causing thrombosis and ischemia. These are the various ways vasculitis can present clinically. These are the basic pathologies, how the patient would present to you. So we'll come to the classification of vasculitis, basically broadly classified into large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. So large vessels are basically aorta and its branches up to the origins. Okay. The medium vessel from the origin, branches of the aorta from the origin till they lose their muscular coat. These are medium vessel. Once they lose their muscular coat, they are classified as small vessel vasculitis. So the large vessel vasculitis, the most commonest disease is Takayasu arthritis, and in elderly is giant cell arthritis. Medium vessel vasculitis, the common presentations are polyarthritis nodosa or panarthritis nodosa or Kawasaki's disease. And small vessel vasculitis, there are two more components, One is immune complex mediated vasculitis and one is ANCA associated vasculitis. In immune complex mediated vasculitis, HSP is commonest, cryoglobulinemic vasculitis, and hypocomplementing urticarial vasculitis. ANCAs, 3, GPA, eosinophilic granulomatous and polyangiitis, EGPA, and MPA or microscopic polyangiitis. Now we go to the Chapel Hill classification. Again, large, medium, and small. We've already spoken about these classifications. The other classifications include single organ vasculitis, vasculitis associated with systemic diseases, and vasculitis associated with other probable etiologies like hepatitis C, hepatitis B, syphilis, drug-associated immune complex vasculitis, drug-associated ANCA vasculitis, cancer-associated vasculitis, and others. Behçet syndrome and Cogan syndrome come under the variable vessel vasculitis, which can present with medium vessel or a small vessel vasculitis, sometimes a large vessel vasculitis. So it has all three what is panarteritis. Okay, so you need to understand this classification so that it helps you diagnose and put that patient in a particular basket so that the therapies are defined. So when to suspect vasculitis? In general, the presence of vasculitis should be considered in patients who present with systemic or constitutional symptoms in combination with evidence of a single or a multi-organ dysfunction, depending upon what kind of vessels are involved. So briefly, what are the non-specific symptoms of vasculitis? Are fever, arthritis or arthralgias, myalgia, weight loss, and night sweat. These are called as constitutional symptoms of vasculitis. Specific symptoms to each disease depending upon what kind of blood vessels are involved. Large vessels are involved, medium vessels are involved, and small vessels are involved. We'll come into the details of how each of these vasculitis can present in the subsequent slides. A history of eye inflammation, particularly scleritis, are features sometimes observed in vasculitis. Persistent nasal crusting, epistaxis, or other upper airway disease is suggestive of GPA. Unexplained hemoptysis should always raise a concern for alveolar hemorrhage and ANCA-associated vasculitis. Patients with suspected glomerulonephritis must be evaluated for possible vasculitis, especially ANCA-associated vasculitis or anti-GBM disease. A combination of lung hemorrhage and renal insufficiencies, often referred to as pulmonary renal syndrome, should immediately raise concern for vasculitis, as we saw in the first case that I presented. The presence of an acute food drop or wrist drop may be due to a motor neuropathy from an ischemic process secondary to vasculitis. A limb claudication, especially in upper extremities or in a person at low risk of atherosclerosis, is suggestive of an arterial occlusion from Takayasu arthritis or giant cell arthritis. Especially Takayasu arthritis, a young lady coming to you with limb claudication, you should definitely suspect a large vessel vasculitis, and clinical examination would confirm your diagnosis. Propensity of certain disorders to present in certain age groups very clearly helps us to diagnose certain disorders with much accuracy. Like in childhood, Hinoch-Schönlein purpura and Kawasaki disease are very, very common. In young individuals, Takayasu arthritis, giants, GPAs, EGPA, and polyarthritis nodosa can present. In elderlies, it is usually the giant cell arthritis. So age also helps us in diagnosing probable causes for vasculitis, and it helps us to direct our investigations accordingly and effectively. What are the physical examination findings? Usually, findings of a sensory and or a motor neuropathy. Both subtle and extensive neuropathies can occur in many forms of vasculitis. These include classical mononeuritis multiplex or peripheral symmetric or asymmetric polyneuropathies. Skin lesions are telltale signs of vasculitis. Just by looking at the skin lesions, you can diagnose many vasculitis. The common skin lesions that are seen are purpura, papules, nodules, and livedoid vasculitis. So clinicopathological correlations generally are the purpuric lesions, papular lesions, pustular lesions, and necrosis are usually seen in small vessel vasculitis. Nodules, livedo, and necrosis involve smooth muscle wall vessels and present in medium vessel vasculitis. Palpable purpura is a strong sign of cutaneous leukocytic clastic vasculitis and is a common finding in many small vessel vasculitis as well as in polyarteritis nodosa. HSV is one of very common presentations. Uh, Absent, diminished, or tender pulses, bruit, or blood pressure discrepancies are markers for large vessel vasculitis, typically Takayasu's arteritis. Hence, a careful, full vascular examination is helpful in identifying signs of large vessel vasculitis. A lot of patients, uh, present with very high blood pressures, very low blood pressures. So you need to ideally, if you're thinking of a large vessel vasculitis, you should check the blood pressure on both the limbs, all the limbs. You should compare the limb pressures, and if the difference of more than 10, you should suspect a large vessel vasculitis. Checking the pulses all over. For example, the radial pulse, the brachial, the dorsalis pedis, the popliteal, the femoral. So with thorough clinical examination of all the vessels is necessary for diagnosing a large vessel vasculitis. So when you're suspecting vasculitis, definitely check for all the pulses. What are the laboratory tests that you need to do for diagnosing vasculitis? The initial laboratory evaluation of a patient suspected to have a vasculitic syndrome should include a complete blood cell count, serum creatinine, liver function studies, ESR, CRP, serologies for viral hepatitis, because hepatitis B and hepatitis C are known to present with vasculitis, urine analysis with urinary sediments. Blood cultures should be drawn to exclude infections, especially infective endocarditis. In an infective endocarditis, sometimes the ANCA levels can come positive. Then it becomes a very tough call to diagnose or differentiate between an infective process versus a vasculitic process. So you really need to draw cultures whenever you are in doubt. Cultures are the only way sometimes you can separate out an infective endocarditis from a vasculitic process. So you should have a broad approach to vasculitis, obviously considering all the differentials and not sticking to preformed conceptions, notions about a particular disease. So a lot of other diseases can present like vasculitis. Those are called as vasculitic mimics. You should be aware of the mimics as well, because the treatments can totally differ and affect the outcome of the patient. What are the specific tests that you need to do? Obviously, ANA comes as one of the commonest tests that we send for any kind of autoimmune disorder, which includes vasculitis as well. Complement levels, a low C4 may be present in mixed cryoglobulinic and lupus erythematosus, but not in most other forms of vasculitis. So low C4 is specific for cryoglobulinic vasculitis, and obviously lupus is one of them, one of the other diseases. ANCAs, obviously not completely diagnostic, but positivity to PR3 or MPO are extremely specific for ANCA vasculitis. One caveat I told about is in infective endocarditis, where the ANCAs can come positive, but however, it is not ANCA vasculitis. So often 95% specific for diagnosis of ANCA-associated vasculitis in patients with some reasonable pretest suspicion like a upper respiratory, a lung involvement, or a kidney involvement. Additional tests, obviously chest X-ray or a high HRCT is definitely recommended if you have upper respiratory or a lower respiratory complaint. EMG, NCV definitely helpful in diagnosing neuromuscular diseases and finding suggestive of mononeuritis multiplex. Sometimes the patients who have CNS vasculitis, just a second. Hello.
Yes, please.
Yeah, just a second, ma'am. Yeah, I'll just start sharing again. I think it's sharing, no?
Yes, yes.
Yeah, sorry. So I got distracted by a phone call. I'm so sorry. So biopsy, okay, yeah. Uh, chest radiograph. Yeah. So biopsy, a temporal artery biopsy should always be performed in cases of suspected GCA. Skin biopsies from purpuric lesions, renal biopsies in patients with suspected glomerulonephritis have high diagnostic yields. However, for patients with suspected Takayasu, biopsy may not be possible, except in cases where surgical repair was conducted. Tissue from the aortic arch and its primary branches is not feasible, and the diagnosis is based on other clinical and radiological findings. So biopsy definitely helps us, as you saw in the second case, where we did not have any serology which had come positive. Biopsy, definitely the nerve biopsy gave us a clear picture of vasculitis. So hence, biopsy from wherever possible, for example, a temporal artery biopsy or a nerve biopsy or a skin biopsy or a renal biopsy definitely helps us in, helping us in diagnosing the exact pathology of vasculitis. Vascular imaging, magnetic resonance imaging, MR angiogram, CT angiograms, vascular ultrasound, and PET scan are usually used to detect large artery lesions, and especially CTs and MRIs have become the standard approach to screening for large vessel vasculitis. So, PET scan and overlap CTO, definite CT angiogram definitely helps us to guide the therapy also sometimes in the long run. For example, the activity versus damage. So PET scan definitely helps us in follow-up scans to decide about how aggressive we need to be with the therapy. So imaging has become a very crucial part of diagnosing and managing vasculitis in the long run. Angiograms of the mesenteric or renal arteries in polyarteritis nodosa may show aneurysms, occlusions, and vascular wall irregularities. Angiography is unlikely to be helpful in assessing a small vessel vasculitis because the affected vessels are below the resolution of usual angiograms. So angiography doesn't help in diagnosing small vessel vasculitis. This picture on the right shows these classical aneurysms which are noted in the polyarteritis nodosa. Ultrasound is very useful and a very cheap and effective way of diagnosing certain vasculitis, especially in giant cell arteritis. Nowadays, USGs with contrast is available, which gives you very clear picture about how the vessels are involved and what kind of inflammation is happening there. You can see the halo sign, which is very classically seen in temporal arteritis. So ultrasound is also becoming a very useful tool in diagnosing and managing vasculitis. What are the differential diagnoses? As I said, there are a lot of vasculitic mimics. Very important to know these disorders like infectious diseases are infective endocarditis, hepatitis B, hepatitis C. NHIV also can present with vasculitis. Why these are important is you treat the primary infective cause, the vasculitis obviously comes under control, and it is easy to manage the disease once your primary trigger has been controlled. Atherosclerosis can present with gangrene and can get confused with vasculitis. Thromboembolic disorders, congenital causes like aortic coarctation, middle aortic syndromes, hereditary syndrome disorders, Ehlers-Danlos can present with lot of aneurysms, which can confuse between medium or large vessel vasculitis. Fibromuscular dysplasias again can confuse us with medium and small vessel vasculitis. Hypercoagulable states like APs and TTP need to be ruled out, especially with patients presenting with gangrene. Vasospastic disorders, other multi-system inflammatory disorders like sarcoidosis and Suzak syndromes can present with a lot of vascular involvement. Malignancies, iatrogenic and IgG4 disorders are also very close mimics of vasculitis. Salient features of some common vasculitic syndromes I will discuss because we've been through a lot of vasculitic disorders, but which some of them are very common, and we obviously need to understand and know about these vasculitic disorders. So we'll start with the small vessel vasculitis, which is ANCA-associated vasculitis, or the first presentation would be the GPA, or previously known as the vaginous granulomatosis. Now, the blood supply in GPA affects three organ system, basically the upper respiratory tract, the lower respiratory tract, and the kidneys. The upper respiratory tract, patients can present with saddle nose deformities, chronic sinusitis, otitis media, mastocytitis, and perforation of the nasal septum. Lower respiratory tract, hemoptysis, shortness of breath, chest X-ray, which can present you with cavitating lung nodules. We have seen in the first case which I presented, can present with diffuse alveolar hemorrhage also. Kidneys, yes, we again classical presentation would be hematuria, sometimes have a crescentic, rapidly progressive glomerulonephritis. Urine shows RBC cast like we saw in the first case. How not to get confused with GPA and Goodpasture syndrome? Because Goodpasture syndrome, lower respiratory tract symptoms and glomerulonephritis, no upper respiratory tract symptoms. So it is again a vasculitis where upper respiratory is not involved, but lower and kidney involvement is involved there. So GPA and Goodpastures are differentiated by lack of upper respiratory tract symptoms. Small vessel vasculitis, again, the second classification would be the microscopic polyangiitis. They have dominantly lower respiratory tract symptoms, can present with crescentic glomerulonephritis. Upper respiratory tract symptoms are usually absent, can be precipitated by medications, especially antibiotics like penicillin. P ANCA antibodies are usually present. The vaginous usually present with C ANCA, PR3 and P ANCA MPO. So nowadays, the method of testing has been changed. Previously, we used to focus more on the immunofluorescence, but now ELISA is the recommended technique. So you, rather than asking for a CNCA with immunofluorescence or a PNCA with immunofluorescence, you should ask for a PR3 by ELISA or an MPO by ELISA. That will be more specific in diagnosing. A lot of standard laboratories would do both to confirm and then give you a final report. The differentiating factors between a GPA and microscopic polyangiitis is lack of granulomas. Okay, so granulomas are absent in MPA while it is present in GPA. ANCA-associated vasculitis, the third category would be EGPA, which is usually diagnosed with adult onset asthma, the sinusitis, skin nodules, and purpura. Patient can present with mononeuritis multiplex, wrist or foot drop, transient migratory pulmonary infiltrates, opaque densities on the chest X-ray can be seen. CBC shows significant eosinophilia. Lab testing will show increased IgE levels and increased P ANCA antibodies. So this is how we diagnose the small vessel vasculitis with salient features of GPA, MPA, and EGPA. Immune complex mediated, which is the non-ANCA small vessel vasculitis. The common presentation would be immunoglobulin A vasculitis or HSP, usually present in the younger age group, can present in adults also. Most common vasculitis in children, usually followed by a mucosal infection, a viral upper respiratory tract infection, or a group A streptococcal pharyngeal infections, which is very, very classical in childhood. They present with palpable purpuras on the buttocks and the lower extremities, can present with colicky abdominal pain and gastrointestinal bleeding, and have migratory arthralgias. The small vessel vasculitis can affect the skin, the GI tract, the joints, and the kidneys. So hematoma in the intestinal wall can sometimes present with intussusception. In adults, whenever the presentation is happening, although it is not very common, they do have GI and renal involvement. HSP generally doesn't require anything more than just steroids to control the disease. But sometimes if you have a significant renal involvement or a GI involvement, sometimes a second line agent may be required in HSP in presentation in adults. Immune complex mediated immunoglobulin A vasculitis, which is called as HSP, presents with nephritis, chronic kidney damage, and renal failure, which is also called as Burgess disease or IgA nephropathy. But Buerger's disease is thromboangiitis obliterans. So you should need to differentiate between the two. Buerger's disease is basically a occlusion. It has no vasculitic component to it. Small vessel vasculitis, immune complex mediated. Another syndrome is the Behçet syndrome. It is most commonly seen in the Turkish and Mediterranean population, associated with HLA B551, precipitated by HSV or parvovirus infections. Symptoms are recurrent aphthis and genital ulcers, uveitis, and erythema nodosum. they can present sometimes with large or medium vessel vasculitis and small vessel vasculitis. So Behçet's can present as a panarteritis. So it is not restricted. That's why it is called as, comes under the variable vessel vasculitis category also. Small vessel vasculitis, immune complex mediated cryoglobulinemia. So basically, abnormal immunoglobulin proteins which stick together in cold temperatures, leading to blockages and causing vasculitic symptoms, usually associated with hepatitis C infections. The cryoglobulins start depositing in the small blood vessels in the skin, can present with palpable purpura, sinuses of the nose, ear, and the digits, and Raynaud's phenomena. Small arteries supplying the glomerular, if it gets affected, can present with glomerulonephritis. Small arteries supplying the peripheral nerves can present with peripheral neuropathy. So cryoglobulinic vasculitis can present with skin lesions, renal involvement, and peripheral neuropathy. Small vessel vasculitis, immune complex mediated, cutaneous small vessel vasculitis. So basically inflammation of the small blood vessels in the skin, and there is no internal organ involvement. It's basically restricted to the skin. Usually happens after 7 to 10 days after using certain medications, example penicillin, cephalosporins, allopurinol. After infections like Streptococcus pyogenes, hepatitis C infection, or HIV infections. The presentation is usually a palpable purpura, dominantly over the lower limbs. Sometimes can present on the upper limbs also. Histopathology shows perivascular inflammation of the small vessels, disruption and destruction of vessels, fibrinoid necrosis, and extravasation of RBCs in the histopathology. So it is basically restricted to the skin and doesn't require any aggressive therapy. So basic features of the most commonest small vessel vasculitis, you can go through. Main organ involvement in GPA is usually the lung, kidneys, nose, that is upper respiratory. MPA is usually the kidneys and the lungs, upper respiratory is not there. EGPA can have the upper and lower respiratory involvement, peripheral nerves, heart, and skin. Rate of renal involvement is quite high with GPA, very, very significantly in MPA, and not much in EGPA. Prodromal symptoms may include sinusitis, upper respiratory infections symptoms, and EGPA. Asthma is a very significant finding in EGPA. ANCA positivity, very high in GPA and MPA, not much in EGPA, although PANCA can be positive. PR3 very strongly positive in GPA. It can be positive in MPA and EGPA, but lesser chances. While the PANCAs comes very strongly positive in MPA, can come in either of the other two disorders, but less common. Coming to medium vessel vasculitis, polyarteritis nodosa, so also called as necrotizing vasculitis, usually happens in middle-aged men, usually presents with a very high, significant hypertension and vasculitic symptoms. So what are the involvement is renal, coronary, and mesenteric arteries. In renal, they cause secondary hypertension, renal failure, and hematuria. Coronary, they can present with acute myocardial infarctions, and mesenteric arteries, abdominal pain, and bloody stools. Skin manifestation can also be a presentation, can present with cutaneous vasculitis, livedoid reticularis. So a lot of skin manifestations are also there with polyarteritis nodosa. We had seen an image in angiography where they showed these aneurysms in the renal arteries. So polyarteritis nodosa, renal, coronary, and mesenteric artery can also have skin involvement. Ischemic to multiple peripheral nerves, mononeuritis multiplex is another presentation of PAN. It usually spares the pulmonary arteries. 30% of the individuals positive for hepatitis B surface antigen, immune complexes that develop in response are responsible for the vessel damage. So, polyarteritis nodosa, hepatitis B is something which is very, very common. Cryoglobulinemic vasculitis is hepatitis C. So that is very, very common infective triggers for these kind of vasculitis. So polyarteritis nodosa, renal, coronary, and mesenteric, and can present with peripheral neuropathy as well. Kawasaki disease, another medium vessel vasculitis. You can remember as crash and burn. Basically, it happens in less than 4 years of age. Conjunctival redness, rashes, which is polymorphous maculopapular, adenopathy, a large enlargement of cervical lymph nodes, strawberry tongue, glossitis and other mucosal changes, hands and foot changes, including erythema, edema, and desquamation of the hand, and burn. The fever lasts for more than 5 days. So Kawasaki, easier to remember, crash and burn. So now coming to the large vessel vasculitis, we'll come to the comparative slides once we finish off the overview. So large vessel vasculitis, Takayasu arthritis, the usual presentation is less than 40 females, most commonly of Asian descent. Branches of the aortic arch are involved, example, the subclavian artery. They have weak upper extremity pulses on one side. Sometimes pulseless disease also is another name for Takayasu arthritis. Blood pressure discrepancies between the two arms have to be at least more than 10 millimeters of mercury. So that's why we had discussed that, a careful clinical examination for all the pulses and bruit is very, very important in diagnosing Takayasu arthritis. Takayasu arthritis can be a very, very clinical diagnosis and very, very rewarding for a young individual, for a young lady who comes to you with, sudden onset hypertension. Patients can present with strokes, with hypertensive emergencies. And it is very, very important that you check all the pulses when you're suspecting a large vessel vasculitis. Another large vessel vasculitis is temporal or giant cell arteritis. The commonest symptoms are, scalp tenderness, can present with blockage of the ophthalmic artery, can lead to sudden blindness. Constitutional symptoms can present with a disease called as polymyalgia rheumatica. Polymyalgia rheumatica is closely associated with GCA. Polymyalgia rheumatica sometimes can be a separate entity altogether without a GCA, but they are very closely associated. So anybody who comes to you with recurrent headaches, scalp tenderness, fever, weight loss, very high ESR, pain in the shoulder girdle and the pelvic girdle muscles, you should look for vasculitis also. So if you are suspecting a polymyalgia rheumatica, very, very important is very high ESR. So anything, very non-specific constitutional symptom, very, very high ESR, in an elderly lady, you should start thinking about giant cell arteritis. So basically, it is a granulomatous inflammation featuring monocytes. Large multinucleated cells called as giant cells are seen. Intimal thickening, fragmentation of internal elastic lamina, and affects intermittent segments of the vessel. Sometimes that's why when you take a biopsy of the temporal artery, you need to take a big chunk of the vessel rather than going taking a small piece sometimes, because there are a lot of intermittent involvement. We can sometimes by mistake take a biopsy of a uninvolved part of the vessel. So you need to take a fairly longer length of temporal artery to look for histopathology and diagnose temporal arteritis or GCA. So polymyalgia rheumatica, GCA, very closely associated. We'll come to the comparative slide. Patients, young women below 40 years, common in Asia. Individuals over 50 years of age in Caucasian origin in GCA. GCA is not very common in India, but we do have uh, cases, but then it is not as common as Takayasu. The common involvement of target vessels are usually aorta, pulmonary arteries, and sometimes cardiac vessels are also involved. Extracranial branches of external carotid artery and aorta in GCA. Systemic pre-occlusive phase usually have this claudication symptoms, and then comes the occlusive or the ischemic phase when you have blockages and, gangrenes and organ involvement or organ damage. Temporal headache presentation, jaw claudication, very, very important. Visual loss, sometimes can present with very acute vision loss, and other systemic and musculoskeletal symptoms like polymyalgia rheumatica. Imaging modalities for Takayasu arteritis, CT, MRI, and PET, as we've already discussed in our investigations of Takayasu. Temporal artery with ultrasound, very, very rewarding. PET CT is also nowadays used. Imaging findings, circumferential vascular wall thickening with peripheral contrast enhancement, the double ring sign, or FDG uptake if there is a lot of activity inside the vessel, which is common to both. So that's why sometimes PET can be helpful in deciding your immunosuppression when you are following up a case of large vessel vasculitis. There are a lot of caveats. There are a lot of disagreements on the usefulness of PET sometimes, because clinically or imaging wise, the vessels may look normal, but there are a lot of studies who have taken biopsies, endovascular biopsy, which shows active inflammation. So there is a lot of controversy regarding the use of PET in the long run management. But yes, at our level, I think uh, PET scan is definitely a imaging modality that can be used. Stenotic segments with aneurysm formation is seen in chronic phases. Temporal artery ultrasound, hypoechoic vascular wall thickening, plus non-compressible arteries. That is very, very classical of temporal arteritis. FDG uptake, we've already discussed that PET scan can be sometimes very misleading. Atherosclerosis can also cause FDG uptake in the vessels. You need to look at the background history of atherosclerotic risk factors, age before you actually label the patient as a large vessel vasculitis. So infectious vasculitis, very, very closely mimicking autoimmune vasculitis. So Rocky Mountain spotted fever, basically rickettsia rickettsii, can present like small vessel vasculitis. Dog or wood ticks can present with petechial rashes on the palms and soles and trunk. So all these things you need to be very, very careful about. But you have to take a good history sometimes, for recent travel before come to a conclusion. Neisseria meningitis, disseminated meningococcemia, small vessel vasculitis, can present with petechiae, purpura, sometimes hemorrhagic infarctions of the adrenal glands. It's called as Waterhouse-Friderichsen syndrome. Syphilis, again, vasculite can present like vasculitis, can present with affect the small vessels, supplying the genitalia, infarctions, skin canker, can cause ischemia to the tunica, weakening of the aorta, can cause aneurysms in the long run, can cause aortic regurgitation. So very much like vasculitis. So you need to be very, very careful, very, very aware of vasculitis mimics, especially infectious disorders, because you're going to immunosuppress the patient. And if you have some infectious uh, cause or a trigger, you might harm the patient rather than helping the patient. So we need to be very, very aware of all the vasculitis mimics, uh, more than sometimes whether you know all the vasculitic names or not. So vasculitic mimics is what you need to be aware of. What are the general principles of treatment? Once you've diagnosed what kind of vasculitis, what are the organs involved, you need to start the therapy. The commonest drugs used are immunosuppressive drugs like steroids, mycophenolate mofetil, azathioprine, cyclophosphamide, and methotrexate. So steroids are the primary stay of therapy in the acute phase, and gradually, depending upon what is the organ involvement. For example, there is a diffuse alveolar hemorrhage, which can be life-threatening. So steroids itself may not work. Sometimes cyclophosphamide, rituximab, IVIG, or plasmapheresis can also be considered in a patient where you have life-threatening presentations with these kind of vasculitis. The common biological agents that are nowadays used are rituximab and TNF alpha inhibitors. Rituximab is now gradually become the mainstay of handling small vessel vasculitis, especially vaginous granulomatosis. So in the induction and maintenance, rituximab is very strongly recommended nowadays in on top of steroids or mycophenolate mofetil. TNF alpha inhibitors, very, very useful in Takayasu arthritis. Nowadays, with refractory Takayasu arthritis or maintenance, TNF alpha is sometimes strongly recommended. Uh, General management, obviously, when you patient present with gangrene or occlusive symptoms, antiplatelets, anticoagulation, and antiviral therapies are used. Antiphospholipid antibody syndrome can present with gangrene, and you might get confused with vasculitis. You need to look for Apla syndrome also, in especially in cases like the second case which I presented with the patient present with gangrene of the digits. So anticoagulation is very, very important in such disorders. Antiviral therapy we have already discussed. Hepatitis B with PAN and hepatitis C with cryoglomerular vasculitis. So appropriate antiviral therapy is very, very important. So newer additions, I would want you all to know there are two new syndromes which have been proposed. Deficiency of adenosine deaminase 2, very, very hot topic nowadays. A lot of research happening on that. In India, PGI Chandigarh, Dr. Aman Sharma is doing a lot of work on that. And, we're trying to get a registry, getting, reporting more cases, although it's very rare. You need to know so that we pick up these disorders. Deficiencies of adenosine amylase 2 or DADA2 is a rare recessive disease that causes systemic inflammation, vasculitis, bone marrow failure, and immunodeficiency. It's caused by mutation in the ADA2 gene, which produces adenosine deaminase 2 or ADA2 protein. The ADA2 protein helps support the lining of blood vessel walls. DADA2 can affect both children and adults and is often diagnosed in early childhood. But yes, adulthood presentation is also noted. What are the common symptoms? Repeated fevers on and off, tendril-like skin discolorations, enlarged liver and spleen, recurrent stroke-like episodes. Very, very important. Um, the DADA2 generally presents in younger age group where they have recurrent neurological complaints like recurrent strokes, recurrent bleeds in the brain. So when you have these recurrent neurological symptoms with lack of other vascular involvement, especially peripheral, you should start thinking about DADA2 and a lot of immune system abnormalities. It presents with a plethora of symptoms, but I think neurological symptoms, recurrent neurological symptoms, skin manifestations, hepatosplenomegaly, and some immune abnormalities like leukopenias, thrombocytopenias should raise a suspicion of DADA2. So as I said, huge plethora. They can have ocular symptoms, cardiopulmonary involvement, gastrointestinal manifestations, mucocutaneous manifestations, immunological manifestations like humoral immunodeficiencies, ANA positivity, low IgG, IgM and IgA levels. Neurological, very, very important. Ischemic stroke, hemorrhagic stroke, cranial nerve palsies, central and peripheral neuropathies, headaches, seizures, hearing loss, very, very important. Hepatosplenomegaly, lymphadenopathy, you should be looking for. Can present with renal involvement, hypertension, renal artery stenosis, hematologicals like lymphopenias, anemias, musculoskeletal like arthralgias. So DADA2 is a very, very interesting uh, uh, clinical syndrome which is coming up in a big way, and people are working on it because it can present in masquerade like any other vasculitis. And the treatment for DADA2 is usually TNF alpha and steroids. So you need to diagnose DADA2 and you can send the gene workup, uh, exome analysis to diagnose this particular disorder. Vexa syndrome is another very interesting presentation, vasculitic presentation, is a rare, often fatal autoimmune disorder that causes inflammation and blood manifestation. It is caused by mutation of the UBA1 gene of the blood cells, which are somatic, meaning that they are acquired at some point in life and not inherited. Vexus syndrome primarily affects males and develops in adulthood. Okay, so you can see that the DADA2 is usually present in childhood and Vexus affects in males and usually in the adulthood. What are the manifestations? Recurrent fever, relapsing polychondritis, polyarthritis nodosa, giant cell arthritis, arthralgias, arthritis, neutrophilic alveolitis, venous thrombosis, lymphadenopathy, scleritis, vasculitis, Siedt syndrome, coexistence with lupus, Still's, macrophage activation syndrome, spondyloarthritis, hematological malignancies. So when you have these kind of presentations, varied presentations, you should start thinking about Vexi syndrome. Again, the diagnosis is through genome sequencing. Thank you. I think we can take questions if you have anything specific to any particular disease or therapy.
Thank you, Raheesh. Thank you, Dr. Raheesh. Excellent talk, wonderful slide. And I think you covered everything from start to finish. Any questions from students?
It's a very vast topic, not easy to cover.
Okay. So we'll have a further session and we'll go into the details of each vasculitis. But this was was just an overview where Raish told us how we should approach it. All these are all systemic diseases, so we should always be on the guard and look at it as a systemic disease rather than just focusing on one system which is involved at that time. Right? Sometimes we have
Hello,
young.
can I ask a question?
Yes, yes, please. Please go ahead.
Yeah, I'm Dr. Karnik.
Yes, yes.
Yeah, excellent lecture. See, I'm at Sion Hospital as a professor and HOD, and we see a few cases of HIV, diagnosed patients of HIV on ART who are presenting with strokes or vasculitis at a relatively young age. I mean, we know that HIV is associated with accelerated atherosclerosis, but in the mid 20s and early 30s, if we, I'm seeing a lot of strokes in or large vessel thrombosis in HIV positive. So what is your take on this HIV with vasculitis? I mean, should we investigate them, or this is just a secondary vasculitis and you go according to that? Many times they are well controlled. Their CD4 counts are good. And despite that, their viral load is less than 1,000 copies per ml. And despite that, they are getting we are seeing a lot of young strokes.
Yeah. So it's very similar presentation, as we've already discussed with hepatitis B, C, HIV per se can present with these kind of vasculitic syndromes. But usually when the HIV is controlled, these presentations are not very common. But then obviously, yes, when you have these kind of presentations, there is no right way to investigate. You just may have to treat accordingly. Because you have to treat with antiplatelets, blood thinners sometimes, using of immunosuppressive drugs
Yeah,
in these.
that becomes a problem in
Yeah,
with that
it
HIV
is going to be
background.
difficult. I don't think there is any right answer to that. I think there is no specific, clinical syndromes which are diagnosed other than, that vasculitis is another presentation of the primary disease like other viruses. So I think it has to be managed at case-to-case basis.
Right.
Maybe, if things are not working out, a low dose methotrexate or something which may not interfere with your primary uh, viral disease needs to be considered. So
Right.
there is no right answer to it, I guess.
Fine, thanks.
Right? Sometimes we have young patients, non-diabetic, coming with non-healing ulcers. Like I have a young patient with a large non-healing ulcers. How would you
Ma'am,
approach?
your voice is very low, ma'am. Not able to hear.
Sometimes we have young non-diabetic patients,
Non-diabetic?
large non-healing ulcers.
Yes.
So how do we go about in this patient? No
Yeah.
other histories, no systemic complaints, nothing at all.
Yes. That's also non-healing ulcers is a very big challenge sometimes. Obviously, biopsy definitely is worth doing because sometimes you get these, vascular, infiltrates by leukocytes. Sometimes that helps us in diagnosing these kind of cases. Another thing is that you should look for the coagulation profile, where you can add some blood thinners to treating. So it is basically if the biopsy, if they give us some diagnosis, that helps us in deciding on immunosuppressive agents. Uh, as we have already seen that cutaneous vasculitis just limited to the skin, affecting or presenting like pyoderma gangrenosum or basically cutaneous vasculating leading to ulcers. They generally do respond to immunosuppressive therapy. Biopsy is one thing which can help us. Sometimes if they don't, then I think it's a lot of empirical therapy that we use, like colchicine and low dose steroids to see how the patient responds. So many times, these low dose immunosuppressive therapies are useful. Or sometimes if it is a very chronic case where they've tried grafts for these non-healing ulcers, recurrent graft failures, then I think it's more empirical to start off with some immunosuppressive therapies. Many times, all the autoimmune workup comes negative. Biopsy sometimes is helpful, but sometimes very non-specific. I think you need to.
Vasculitis, it
Sorry?
would still show a vasculitic features, but it would not tell us the underlying
Yes.
etiology.
So we may not exactly get the etiology, but I think considering the overall picture of how the patient presented, where the site of ulcers, lack of response to previous therapies, which usually a plastic surgeon or a vascular surgeon would have been doing. where they have already anticoagulated, they've already given antiplatelets, a lot of local therapies, hyperbaric oxygen therapies, nothing works. So then probably, it's always worth giving a shot of immunosuppressive therapies. And we do have a lot of cases where they have responded fantastically well to empirical immunosuppressive therapies.
Thank you. Any more questions? Students want to ask something? Okay. Thank you so much, Dr. Raheesh. Excellent
Thank you
lecture.
so much, ma'am.
It's very nice.
Thank you.
We wish
Thank
to
you.
you have a nice weekend with the family.
Sorry, ma'am.
So have a nice Sunday with the family.
Thank you
You'll
so
get
much.
more and all permission. Yeah. Take care.
Thank you so much, ma'am.
Bye bye.
Yeah.
Thank you, everybody. Thank you, students.